All right. Good afternoon, everyone. Thank you for joining us today. My name is Haley Troy, and I am a coordinator at the Center for mHealth and Social Media at the University of Connecticut. I'm honored today to introduce our speaker, Dr. Thomas Agresta. Dr. Agresta is the interim chair, professor, and director of medical informatics in the Department of Family Medicine at UConn Health Center. He is a seasoned family physician and clinical informatics educator, administrator, researcher, and innovator with a history of bringing together multidisciplinary teams to focus on developing novel methods for creating, using, and evaluating technology in both clinical and teaching settings. He has a bachelor's in biomedical engineering from Stevens Institute of Technology, a medical degree from New Jersey Medical School, and a master's in biomedical informatics from Oregon Health Sciences University. He oversees the electronic medical record for the Family Medicine Residency Clinic and has held state-level leadership roles in adoption and implementation for health information exchange and electronic health records. He also served as the section leader for informatics in the Connecticut Institute for Primary Care Innovation, a joint venture between the University of Connecticut and St. Francis Hospital. His research interests include using technology to enhance the care of patients, as well as the experience and efficiency of providers. He currently leads the Health Interoperability, Innovation, and Learning Lab, which is focused on providing education, outreach, and research focused on technology-enabled healthcare delivery. Today, Dr. Agresta will provide an overview of health information exchange, including its history, value, and future opportunity. He will discuss the progress made to date in Connecticut by Connie, the state's official health information exchange, as well as the national landscape of health information exchange. So thank you again for tuning in. We ask that you please save all questions for the Q&A at the end, at which point you'll be able to unmute yourselves or submit questions in the chat. I will now turn things over to Dr. Agresta.
Thank you, Hallie. So today I want to talk a little bit about health information exchange and to talk a little bit about it as both a noun and a verb. And if you can go to the next slide. So what is health information exchange, or HIE is the shorter abbreviation is. It basically allows us to electronically move clinical information between different systems, and hopefully allows us to also maintain the meaning of that information being exchanged. It helps us to enhance our public health, and it also helps with improving clinical safety, efficiency, and effectiveness. The term HIE is also used as either a verb or a noun. The verb is the actual act of exchanging healthcare data. And the noun is actually an entity that coordinates or governs that data exchange. And that we're going to kind of go through a little bit of both the verb and noun aspects of stuff. So why is it important to do health information exchange? If we go to the next slides, why are they important? If we take another step forward and look at the next slide, and think about our own setting. I'm sitting here at UConn Health, and about 6 miles down the road from me, is Trinity Health and Hartford Healthcare, along 84. There are a number of small practices, some skilled nursing facilities, home health, agencies, visiting nurse agencies, EMT, settings, all in that 7-mile drive. And in that 7-mile drive, there's a lot of healthcare that needs to get delivered, both in those clinical settings, but also day-to-day in people's homes. And if you think about, what is the currency of that, and what might happen to a given patient, they may actually visit in the course of a year or a couple of years, they may actually visit all of those different locations. They may experience primary care in a small practice, go to one of the hospitals in the region, be admitted to a skilled nursing facility, and have home health care services all within the course of a few weeks. right? And in fact, I see that, pretty routinely in my own clinical practice. I see patients in Hartford, and that often happens. Go to the next slide. So let's walk through some hypotheticals. And this is not really hypothetical because it really happens, right? So suppose somebody is new to your practice, or they just recently got discharged from all of those different settings we talked about. The ability to have access to the variety of different data that is made during those encounters is really critical in order to care for that patient in front of you. And what kinds of data are really important? Well, the actual information that they went in or out of a clinical setting, in or out of a hospital or an ER, for example, the ability to see the actual notes that the clinicians who are discharging a patient might have made about them, the ability to look at and modify and improve their medication lists because they change from place to place, the ability to kind of compare or look at x-rays that may change as somebody goes through a change, say they get a pneumonia and they get some improvement. And obviously the ability to kind of take a look at and monitor their laboratory and other kind of studies over time. All of those things, if done well and done efficiently, can dramatically improve the care of a patient. But what happens today? Well, there is some data exchange that is happening today, but it's not, I would say, optimal. And we're going to talk a little bit about what's actually happening today and how it happens a little bit today, and a little bit about where we'd like it to go, perhaps, to be optimal. People have been exchanging healthcare data right since the beginning of healthcare. In the past, it would generally go with the patient in some fashion. They might have to copy things and carry it. Then there was, faxing that would send information, somewhat electronically, right? And more recently, there have been in the mid 80s, there were regional health information exchanges that were created where they were able to kind of exchange data in a somewhat technical way, essentially by what accounts, amounts to, secure email. And those were the mid 80s and 90s, actually, really, up into the early 2000s. As electronic health records have gotten more sophisticated and have covered larger portions of healthcare entities, large EHRs like Epic or Cerner actually have built into them the ability to exchange some data in between one version of Epic and another. And those are all forms of health information exchange, and they all do help. But they don't necessarily kind of correct for that problem we saw with the road, where many different practice types and many different clinical environments exist, and many different kinds of electronic health records or data that maybe is not even in an electronic format are still being utilized regularly. If we go to the next page, so obviously the new patient, if you had an effective health information exchange, you could tell that Mrs. Smith arriving at your office, was admitted to the hospital, had several different, medications ordered, and you could actually care for her more efficiently and effectively. If you go to the next page, or next slide, we can also talk about, well, what can you do if you've got access to data on a number of patients at the same time? As we know, many of our healthcare systems now are, essentially set up as accountable care organizations, or they're responsible for a population of patients, and they're looking at trying to control costs and also improve quality across those patient groups. And if you have the capacity to actually see information related to quality, and the examples shown on the screen here are fairly common ones. There are diabetic patients, for example, and in diabetes, we want to be able to look at whether people have had a recent A1C, which is a lab value that helps us monitor diabetes, whether they've had eye exams done, whether they have had their feet examined, and a variety of other things. But often these things can occur in different places. The data can be in a lab system that is not connected to your electronic health record. The eye exam may be done at an optometrist or ophthalmologist's office where the individual does not have an electronic health record, or it's a different one again. So there's a lot of missing data. So if you had a health information exchange where that missing data was put in from the various systems into that health information exchange, then you might be able to look across that data. And on the right side is an example of a mock-up of a portal that shows lab data, and eye exams that were done, for example. And you might be able to look in that portal or in something akin to a portal and be able to find the missing data and kind of put it into your system so that you could monitor your populations well, and care for them in that fashion. And we're getting to the place where we're starting to be able to do that. But I can tell you, most healthcare organizations still struggle with actually doing population health well. If you go to the next slide. So what happens when we're not doing it well? We're wasting time. We're paying for that time. Somebody is looking for the colorectal cancer screening. They're looking for the diabetic testing. They're looking for people with chronic renal disease and whether they've had renal function tests done. So what can we do? We can and have started to actually put together health information exchanges where that data that's present in other systems can get passed into that HIE, and through that HIE can get pushed forward to the clinicians or the teams that need to utilize them. And then let's take a look at what the value is. So if we go to the next slide rather. It's about a patient. That's why I said next patient. So what is the value? So there have been a number of studies about the value of the health information exchange for various different types of HIEs throughout the U.S. And what the potential value is. So one obvious value is to patients. And one of the things that can happen with a HIE is that you can, by the nature of seeing what has been done in another setting, and by seeing the lab tests that have been done and the clinician's thoughts in another setting, it often can lead to a more rapid diagnosis. When somebody has evolving symptoms over time and they show up in an emergency room with increasing symptoms of pain, for example, in their abdomen, and you're able to kind of look at what's happened in the past, you're able to get much more rapid diagnoses, perhaps. And that's only if you can get access to the data effectively. You can target your treatment a little better. Okay, if you found out that certain medications have been tried in the past and they have not been effective for controlling someone's blood pressure or dealing with something, you can switch to a medicine that's maybe not in the same class, but have that more targeted treatment. There have been demonstrations in the past that have shown better outcomes on a population level for patients who are, especially in the ER setting where data was accessed through a HIE. Because you can see what other radiology tests have been done in the past, there has been proven ability to kind of reduce the number of X-ray tests done and therefore reduce radiation exposure. The ability to actually monitor for that over time has also been incorporated into some health information exchanges. And then obviously, if I can see that a patient of mine has had a laboratory test like an A1C, which is a monitoring, for glucose levels in a diabetic patient, if they've had one done 2 months ago or a month ago in another setting, I do not need to repeat it myself. So there's less repeat lab testing. In the places where they've actually monitored the costs to a system, to a healthcare system, or to a payer, in places that have implemented health information exchange, they've seen less overall cost associated with the care when clinicians actually use the health information exchange. If they don't use the health information exchange in that same setting, the cost goes higher but there may be reasons for some of that. Go to the next page or next slide. And then depending on where you are in the healthcare role or setting, there are value that can be provided to the healthcare providers. It's really critical. One of the things that is very, very important to recognize is that healthcare is a pretty uh, challenging task to accomplish, especially with the use of computers in everyday clinical care and delivery of medicine. And so when HIE data is put directly in the path of the physician or clinician's workflow, it really can be helpful. It can lead to, as we noted, more rapid diagnosis, certainly less waiting for studies if you don't need to accomplish, do those things. So in an ER, they've shown that when people have been to other settings and gotten lab tests done, that your actual time in the ER is shorter. The ability to compare a study, from one setting to another, to X-rays done over time in different places, can really help the clinicians to, achieve their jobs. And then, there has been demonstrated improvement in quality metrics and ability to collaborate through some health information exchange. So these have all been demonstrated through literature and through other projects. So next slide, please. So what's the potential value to employers or insurers, the payers, the state, in essence? Obviously, reduced cost and duplicative testing and improved outcomes are also noted to be important. But from a payer perspective, an employer perspective, there is a noted improvement in the satisfaction of their patient, the people that they employ, especially when they have less time that is needed to be taken off for second opinions and for repeat testing and things like that. And all those things have been noted with the onset of the use of health information exchange. So we go to the next slide. We'll talk a little bit about some of the models of HIE that exist. This is perhaps a slight bit dated, but it does demonstrate, I think, the three sort of basic distinct models around how data can be accessed from a health information exchange. In one model on the left, you can see that there's various different data sources available for healthcare data. Variety of different electronic health records, maybe some things in a personal health record, or in an immunization registry, or even a state's level eligibility data for their Medicaid population, for example. And in the centralized model, when that data is changed or updated, it's pushed into a central clinical data repository, or a central data repository that may not just be clinical information. And then when an individual needs to access that information, they're able to log into either a portal or some other fashion, gain access to that, look up a patient, and then find their information. In a federated model, which is the middle section, essentially what happens is in the middle is just information about patients, and usually about providers who have access. Whoever has access also needs to be, very well spelled out. And then a little bit of information about where data exists. So for example, if I was to visit a hospital, the information that I had visited the hospital, and for a very limited amount of information about what was available in my source system, the electronic health record at the hospital I visited, would be sent over to this central area, and that information would would stay present in this record locator service. And then if a clinician needed to see me for some reason, they would log into this federated model, into a portal or some other fashion, find the information that was about me, and then go ask to retrieve it. So essentially, there would be an electronic request sent to the original source of data to basically say, please send me, the data about, Tom hospital stay, right? And it wouldn't necessarily kind of know all the, places that I'd been or all the data about me at the same time. The most common model that is currently in use, and there's two other models were developed early on, and for different reasons, in terms of different use cases, but also for different safety and privacy approaches. The third model is actually the most common model that's in use today. And in fact, it is the model that is utilized for Connecticut, and it has a hybrid. And in the hybrid model, essentially you are having information about patients sent to a clinical data repository or central repository. There still is this master patient index and the ability to find where the source data is and some information about that source data, that record locator service. But the ability to kind of store some data centrally means that we can retrieve it more effectively, and we can put it together in a view for somebody logging in a much more sophisticated view, so that you can see longitudinal data about an individual. You can look at what has happened over time with for example, with some laboratory information that might be from different sources. And you can do a little bit of more analytics to kind of look at population health outcomes, other types of things. So this hybrid model permits, and it permits also some data to stay in the same source systems, so that, for example, if there was sensitive data, but there was just information about that sensitive data available in the record locator service, then you could say, for example, all right, somebody has information available in a methadone treatment center, and that may or may not be made available to people signing in, depending on privileging. But if you want to get that information, you're going to have to get it permission and go get it from that other source. So there's ways of utilizing these hybrid models that can be very helpful. Let's go to the next slide. So increasingly, one of the things that's really clear about effective use of health information exchange is that we need to have a better way of kind of doing, interoperability. And interoperability requires a lot of different things. It's one thing to, share data, but if it's in a completely different format than the system that I'm logging into and utilizing and caring for a patient with, then that data sharing may or may not be very helpful for me, or it may take me actually more time from a cognitive perspective to kind of take a look at that data. And this is kind of a little bit where healthcare stands right now. I will get information faxed into our office that we then scan into our electronic health record about, for example, our diabetic eye exams. And it's there, it's available in the EHR. It was exchanged with me, but it's not really interoperable with my EHR. I can't, I have to put in something else to keep it that way. So there is a real move afoot, and it has been a decade-long move to try and increase the interoperability. And we'll talk a little bit about what interoperability really is. But it really requires some standards. And at the national level, the Office of the National Coordinator for Health IT, or ONC, has become the guardian of those interoperability standards. And it's authorized by the federal government to kind of create some required standards and some optional standards. And there are different kinds of standards. The standards around data, talk about, for example, how it's in what format is it transmission occur? How does it get transmitted from one setting to another? What does the content of that standard look like? So a data transmission standard might be that things need to move in something called, an HL7 document for those of you who are kind of technical, or for the content, it may be that you have to have it in a CCD, which is just a way of organizing things. For the organization, it may say your CCD has to have certain fields in it, such as the past medical history, the family history, the medication lists. And then there's, information about standards about the format. The format may be that your labs need to be in a standard way of kind of reporting a lab. And the most common thing that you would see in that, it would be a LOINC code. And those are just codes that from one computer to another, you can recognize, that, LOINC code XYZ equals a hemoglobin A1C that's used in diabetes, right? So and the reason we needed to do that is because as people were developing their original laboratory systems, their electronic health record systems, they all developed them in proprietary manners, and initially didn't kind of share how they were organizing them, and it really wasn't, people were not doing that, necessarily on purpose, but in essence, it kind of kept things in a data lock. So the Office of ONC, has activities where they develop these standards, and they get coordinated with at the federal level and the state level, and by public feedback. They actually then have ability to certify electronic health record and health information exchange products. So they actually certify that they function and utilize these things correctly. And then they kind of move that forward. So let's go to the next slide. So there are a couple of different interoperability levels. There is the ability to technically send something, one system to another, right? Then there is the ability to have the predefined formats and structures. And these two things were, handled very early on in stuff with the Office of National Coordinator. The most important things now really are going towards being syntactically and organizationally interoperable. Syntactic interoperability means that the same data has exactly the same meaning from one system to another, so that you could exchange it between two different electronic health records and take advantage of the system's capacity to do clinical decision support, such as figuring out if a drug-drug interaction or a drug-disease interaction occurs. And that requires, syntactic and semantic interoperability. At the level of organization between businesses, that's a bit more of a challenge, and that means that you could utilize it for business purposes and rules. And let's go now a little bit into what's happening in Connecticut. Where are we in Connecticut? So let's go to the next couple of slides. So let's talking about Connecticut Information Exchange. So currently, there are a number of different ways we exchange data in Connecticut. We exchange data from electronic health record system to electronic health record system, such as the Epic shops that have Epic EHR, their ability to utilize something called Care Everywhere, where they're able to exchange Epic to Epic, and more or less getting closer to being syntactically interoperable, but not quite there yet. There is the ability to exchange data also through other types of national exchanges, where there's a lot less of that syntactic interoperability, but at least the data exchange methods are kind of laid out. And then if we go to the next slide, recently, and this is really sort of in the last several years, the state kind of went through a legislative process where they said we're going to have one sort of health information exchange to connect to all the health information exchange activity going on in Connecticut. And we really want to push everybody to kind of utilize this one organization and this one methodology, so that anybody can learn to connect to or be able to connect to that. So in a few years back, a nonprofit entity called Connie, which is Connecticut's Information Exchange, was formed. It began official operations in 2021. By legislation, all hospitals and labs were required to connect within a year. And I'll share with you a little bit later where that stands. And then all other providers with an electronic health record capable of connecting must be able to do so by May 3rd of this year. So pretty soon. And it has oversight by the Office of Health Strategy. And it currently is served by a vendor that has a number of other health information exchanges in the country, in Maryland, Alaska, West Virginia, Washington. So the technology that's being utilized and a lot of the governance and other things that are occurring really are leveraging, a number of other states, their resources and knowledge to do that. If we go to the next slide. So this is the website for Connie. You'll be able to go on this and find some information, about the organization itself, a little bit of information about what's good for how it's good for patients, what about for organizations, et cetera. If we go to the next slide, I'll show you a little bit of the concept of how it's set up for exchange. So like I mentioned, Connie is the connector for all the other places where data exists and can be exchanged from. So if one looks, this can be kind of a confusing slide, but if you look on the left side, there are several other healthcare information exchanges that sit on our borders. The states to our east, west, north all have health information exchanges. There's also an HIE that is sponsored by the Connecticut State Medical Society in collaboration with them, Connecticut Health Link, and those connect into Connie. There are medical groups and private small groups and larger groups on the left that connect in. There are the ability to connect into the federal government through Care Equality and eHealth Exchange. Those are national exchanges that have their own standards and their way of exchanging things. And then on the right, there is the hospitals. There's not 350 hospitals, but there's 35 hospitals and about 5,000 ambulatory practices and ACOs. And also there are insurers, and insurers are connecting into this setup, as well as in the bottom, pharmacies, and on the right, labs. And increasingly, the state of Connecticut, its internal healthcare activities are looking to utilize Connie as a way of connecting to each other. If we go to the next slide, this is probably old by now, and it's only probably a few weeks old, but they're actively in the midst of onboarding. Over 30 hospitals are now live with data sharing already occurring through the Connecticut's HIE. Another 7 or 8 are in technical exchanges, going back and forth the technical process, and one, or I think at this point only one is in already in a legal arrangement. Of the now 2,000 ambulatory practices they've identified, they were able to kind of bring it down a little bit when they looked at groups that were connected to each other. Almost a half of them are connected, and that's primarily through those hospitals. But that's increasing every day. There are long-term and acute post-care, SNFs that are quite a bit behind, but nonetheless they are in the move going forward. So you can kind of see that this is happening. And there's actually, if you look at the bottom, there's a URL for a list. And if you go to the next slide, if you connect there, you would see who's connected, this dashboard, and what are they actually exchanging currently. And so it shows things that are in progress, et cetera, as to what is exactly being exchanged. And what can be exchanged, if we go to the next slide, is a number of different things. Okay, so if you look to the left, what's currently being done is there's the ability to exchange, at the very minimum, admission, discharge, and transfer alerts. Those are called ADTs. And ADTs indicate when somebody's arrived at an emergency room, when they've left an emergency room, when they've been admitted to a hospital or discharged from a hospital. The same can be done for people going in and out of a skilled nursing facility, and even at an office visit in an ambulatory setting. You can actually send an ADT. You can send along with that a CCD, which is a clinical content document, which essentially has some information about that visit. It can include the actual progress note, a discharge summary, radiology reports, et cetera. All those things are currently being shared through Connie, and different organizations are structured now to exchange at the minimum the ADT. Many of them are getting to actually exchanging documents. Some of the hospitals are now doing actual image exchange. So not just the radiology report, but actually the ability to view an image. And then because they're sending CCDAs, they're able to make a best possible medication history, which I'll show you in a moment what that looks like. What is in progress? In the progress is the ability to sort of have patients access their data, to do advanced directives through this, transfer, and to do the ability to electronically have patients consent for different kinds of data being sent and who it might be sent to in the future. So if we go to the next slides, I'll show you a little bit of what it looks like. So this is what the web-based portal would look like for a imaginary patient called Grape Gilbert. And what you can kind of see is that there's clinical data and there's care coordination data. Clinical data is about a particular individual patient. Care coordination may go across patients. But you're able to see a variety of different kinds of things by filtering along the bottom. You can see that there's the ability to see encounters, whom they've been seen by and what they've been seen for. Health records, the actual documents themselves, and then maybe laboratory results, radiology or clinical notes. And then structured documents also are provided and able to be being seen. If we go to the next, and that's a web portal that people all clinicians who have signed an agreement with and have a treating relationship with a patient have the ability to gain access to. But that's a separate portal, like a web logon. If you go to the next slide, we can see that this is an image of the same Grape Gilbert actually showing up within the context of an electronic health record. There is the capacity for certain EHRs to actually pull up this data directly from the patient. So if I'm seeing, Mr. Gilbert in my office and there's information available in the state level HIE, it will automatically retrieve that data and make it available to me in this context for what I'm doing. Currently, Epic, Cerner, eClinicalWorks, and Athena have that capacity. They are working on other electronic health records within the state. If we go to the next slide, this kind of is that example of that best possible medication history. So this is now actually taking data from a variety of different systems, and as say somebody's seen at Hartford, somebody's seen at St. Francis, they're seen in a private practice, and each one of them has medication data. They're able to send these this data through what the CCD, which has a composite of data, and they're able to kind of take this and roll it up into one view about the current medications. And they're able to look back over 90 days, kind of looking back over what's been done in the last 90 days, as well as the current medications. And if you look in the middle, if somebody's been on more than one dose, you're able to kind of roll up and see, the variations in that. If there is confusion about what's the correct thing, you're going to get a little notice in there. But this is helpful for clinicians. Next thing, you can go to the next slide. And this is a little bit of an example of what might be, if you were looking at an imaging report. Let's just say somebody had a radiology exam, and you then went, go to the next slide. We just walk through this. You clicked on the actual image in the image viewer, right? And then you could actually get a preview of the image. So this is actually live in Connecticut, and a number of organizations are now submitting their CAT scans and MRIs and X-rays directly into the state level HIE, and you're able to kind of look at it this way. And this will increase over time to perhaps all of the places that do imaging. But you can imagine this would really be very helpful if you had something evolving over time, or if you're referring somebody to a clinician outside of your organization, et cetera. All right, let's talk a little bit about patients and their access to data, et cetera. So go to the next slide. We all know that it's really important to kind of follow the privacy and security requirements for different patients, and to follow them at the federal level and at the state level. HIPAA, kind of covers the federal level requirements, but there are state level requirements nonetheless that say, mental health data, sexually transmitted or HIV data, and substance abuse data are places that are, particularly sensitive kinds of healthcare information. And so there is the ability for people who have a treatment or a payment or operations, relationship with an individual to kind of see the data that is not of those that type. If you're being seen in a behavioral health clinic or in an STD clinic or a substance abuse provider location where that's all they do, at the moment, you have to get specialized permission to kind of transfer that data with patient consent. So without affirmative patient consent, that data stays in those places right now. That's by Connecticut law. It doesn't suppress all that information from a problem list or a history or medication list that might be in a primary care clinician's record. And that's just important to kind of understand about how the HIE works. If you go to the next slide, patients do have the ability to opt out of having their data shared, but it is a opportunity that's done by kind of going directly to the HIE. There's a URL here as to how to do that, but it is an all or none kind of opt out. So if they opt out, none of their data is shared with people who are looking to utilize it, even in an emergency. There is a little bit of a minimum data set stored so that they can identify which patients have actually opted out. In the future, they're looking in Connecticut to have an optional opt-in for patients who say they want their mental health data and their substance abuse data actually shared with their clinicians, and maybe even have a decision around who they get to see it. Most of my patients in primary care want that data shared with me because they understand that we're going to utilize it in their best interests. So going next to where did things stand? Go to the next slide. It's important to understand that, Connie is also connected to a number of, as are sort of the health information exchanges that occur through, say, Epic, et cetera. They're connected to a number of emerging and changing national exchanges where that data is more and more becoming standardized in terms of how it is being exchanged. So our patients who go to Florida in the summer, winter, I should say, if they go to Florida in the summer, they're probably very warm. But if they go to Florida in the winter, more and more of those patients, we can see their records when they kind of go back and forth now. And that actually is becoming of significant help. But that's a kind of stay tuned, situation, because I think there'll be an improvement in that as time goes along. If we go to the next slide, there's information there on how to reach out and learn more about Connecticut's information exchange, conniect.org, or you can reach out to them directly that way. And on the next slide is a little bit of the other work that we have done in our health interoperability innovation and learning lab. We've done a number of additional webinars on this topic, and you're able to go to this site, and there are about 12 or 13 webinars, a lot of them explaining how health information exchange is accomplished, a lot more technical details and some other examples from other states, and a number of podcasts speaking with leaders throughout our state about the value and how this HIE can actually be utilized most effectively. So feel free to go to that for a lot more information. So last slide. In conclusion, health information can, if set up correctly, if utilized, if put in the workflow, improve the outcomes, efficiency, and cost. It is occurring regularly in healthcare today. Lots and lots of healthcare data is being exchanged on a regular basis anyway. It does require, however, if we're going to do this effectively, significant coordination so that we develop the standards correctly. We need to modify how we're sharing data. It's still a bit of a work in progress. And although we have an official HIE to coordinate at the state level, there's still many additional HIEs already in use in the state as well. And I would say that it behooves us all to try to utilize the state's HIE in an effective way in order for us to kind of, gain the best that we can from it. And if you have any additional information, please feel free to reach out to me as well. And so now we'll turn it over to questions, and I think Haley's going to moderate.
Yeah, I'm happy to provide some questions, but if anyone would like to unmute themselves to ask a question, feel free to do so. You can also pop questions in the chat if that's more comfortable for you. But I can get us started off. So one of the questions I received is, how is this data being aggregated for research purposes? And similarly, what kinds of research are coming out of increased HIE?
So at the current time, the Connecticut HIE, so I'll answer it kind of in two ways. In other states, there is the capacity to access data for research purposes, usually through a very formal process that's carefully vetted by the board and of the HIE, and has appropriate sort of safeguards such as IRB approval, et cetera. And research around efficiency, about effectiveness, about healthcare costs, about outcomes, about which services are actually utilized through the HIE the most often, are all things that people are in the midst of kind of researching. In Connecticut, just recently, the HIE board approved a policy for setting up a similar mechanism that other states have to permit research to occur with the data in the HIE. I don't believe that anybody's taken advantage of that yet, nor do I believe that the policies are kind of in use yet. But those are certainly questions that can kind of be asked of the Connie board or of the of the organization. But there is an intent in the future to utilize it for research. Mostly the data would be de-identified at that point. In all likelihood, that would probably be the majority of how it would be utilized.
Okay, great. I have another question. How, if at all, does HIE handle reportable disease information that would be deposited institutionally with DPH? So, for example, infectious disease or cancer incident diagnoses?
So there are many ways that different HIEs in different states have been set up to kind of handle this, right? So there are states where the HIE is the place where the actual reportable disease is reported, right? And they act as the gateway and the way to transmit that data around a new cancer diagnosis or an STD, and they have the correct privacy and security constraints around that. In Connecticut, that is not currently the way that things are occurring. But currently the Department of Public Health is still the organization that receives that data, and has to be the place where people kind of do the reporting and kind of check on results, et cetera. There is a desire, I would say, to have an evaluation of whether the HIE could play a role in that, going forward, but obviously done in a way that hopefully improves the efficiency of how the clinicians have to handle the data and also respects the privacy and security in an appropriate fashion.
Great, thank you. Another question, is there a way to verify that providers are using this resource to reconcile their patients' medications and histories related to recent hospital admissions?
So I think the question has to do with several different layers, right? It has different layers to it. So is there a way to verify usage of the HIE? I think is the first question. And the HIE has a number of different auditing tools that that are available to it, and is in the midst of trying to figure out which of the things that are present need to be kind of tracked and audited and looked at and reported on, and to whom it is appropriate to report that information, right? Because there's the reporting of just usage, and obviously we've got a very young and early health information exchange in Connecticut, so just the fact that it's being utilized is one metric of, does it have some value, right? Then you get into the question of what's its utilization for. So looking at a best possible medication history, just glancing at it can trigger, the fact that that was looked at, right? But whether it was used to do something is a much more complicated question, right? Whether it was used to actually, improve someone's medication list would require kind of looking outside of the actual HIE and asking people, how did you use this? It's because it's not really electronically traceable as to how do people use it at the moment. It may be in the future if we have true interoperability where somebody can pull it in and you can kind of do, electronic checking on things, then you might be able to evaluate that way.
Great. What are your hopes for the future research initiatives or in the interoperability lab interest that you have moving forward, Dr. Agresta?
So, I think that last comment, that last set of questions about, what in medication reconciliation happens to be an area where I find it is quite labor intensive, challenging, and fraught with complications. And that whole question of how one would utilize that information that could be present in the health information exchange is an area where I have great interest in kind of looking at and researching and trying to connect that information in. I recently submitted a grant to to AHRQ that was trying to look at, could we use information that was submitted into the HIE, utilize mock information to begin with, but could we actually develop a way to integrate that into the electronic health record for a reconciliation purpose? And could we develop it in a way that could get into a handheld version of it for patients so that they could actually participate in the process of helping us reconcile their meds, right? Because it's a patient-driven thing as well. So that's an area where I have interest in terms of potential research. Other areas are reflective of, can we improve our health equity in the state by sharing healthcare data? Can we utilize it in that fashion? Can we use it for other purposes? Telehealth, e-consults, other things like that. I believe that the HIE done well has a lot of potential. HIE done, partially has, may not be as effective.
Great, thank you. I just want to give everyone the opportunity, if they have any questions, feel free to unmute. And you can also pop a question in the chat if you'd like.
Yeah, I have just one very quick question, and that is HIE facilitating teaming among physicians with different specialties, or alternatively, even different disciplines? I'll give you one example, and that is my daughter's was a hydromassage therapist, but 80% of her clients were orthodontal referrals because she was straightening them up and changing their bites, so they had to work together. But HIE certainly has the potential to do that in very diverse areas subject to confidentiality agreements.
Yeah, you're You're absolutely right, and I'll give you. I didn't share it during the presentation about what is one of the next use cases, but you're reminding me of it. And that is we're in the midst of kind of working with the State Dental Association and with dentists on laying out what a dental access would mean for the HIE. And I've had a number of conversations nationally with groups that are trying to do this in other states as well, where a dentist having access to HIE information may reduce their need to try to get from a clinician clearance for an oral surgery, for example, because they'll know that they don't need prophylactic antibiotics because the heart valve they have isn't mechanical, for example.
Precisely.
And so we've had some conversations with some of the dental providers in the state, worked with some folks outside of the state, and dentists technically are required to actually join the HIE here. So that's one of the opportunities that I think. And then the other is that there is a project underway to actually connect around the social determinants of health to actually make referrals and utilize information for people who need services that are social services. And they can get portions of the data, maybe not all of the data in the HIE for access and the ability to help, with housing needs or food needs or mental health needs. And so those are all places where the HIE is actually actively working on projects and trying to figure out how to make those things happen effectively.
Thank you very much.
We have a couple questions in the chat. Can you please comment more on steps being taken related to consent for mental health, behavioral health data sharing, and how far off this is from being implemented and operational in Connecticut? That's from Jessica Queet.
Yeah, and so Jessica, this is really a very active place where they're really working on this quite a bit, and the way that they're working on it is, I'd say, several dimensional. One area that they're doing is they're actively having listening sessions with behavioral health providers. They've had a number of sessions where they've kind of talked about the HIE, talked about how it works, how it functions, what are the what are the tools available to the patients around opting out of data sharing altogether. And then they've been in active work on developing what we call an affirmative e-consent process. And the affirmative e-consent process would be a way to electronically have, initially they would have the provider do this e-consent, and I think this is pretty close to rolling out in the HIE. But the provider in concert with the patient would say, the patient says, yes, I want my data shared. The provider will be able to log in and utilizing their credentials and sort of say, okay, this patient wants their information shared, probably at this point with a scanned document or something kind of affirming that the patient desires that. They're also working on patient ability to actually allow their data to be shared in those settings. And again, it's affirmative consent from those types of organizations that have substance abuse or STD history, et cetera. The bigger challenge with patients is that authenticating and proving that somebody is who they are is a lot more difficult with an individual patient than it is with a clinician or a provider who has affiliations and other ways of kind of validating that they should have a treating relationship with a patient. So it is happening. That affirmative e-consent for patients is definitively being developed, and I would say pay attention to something roughly in the fall is roughly where I would guess this might be coming.
We have one other question, Dr. Agresta. Do you have time?
Yes, I do.
30. Okay, great. So from Lawrence Garber, will TEFCA actually improve interoperability, or is it unlikely to improve beyond what we already have with Connie, care quality, FHIR, direct trust, etc.?
So I think Larry, you were talking about TEFCA. Is that right? I can't see the chat.
Yeah, it's TEFCA.
Okay, so I didn't bring into the TEFCA into the conversation, but TEFCA is a set of governance oversight structures that were set in place by a legal statute at the federal level for health information exchange, and it's essentially got a governance of how HIEs will communicate with each other. And it's setting the standards for how data will get transmitted, for what kinds of data, for what formats of data will be permitted. And there are a couple layers to that. There is the sort of national leader that, is set up as Sequoia Project is the group that's set up there. And then there are quality health information networks, QHINs. So if you're asking, do I believe it will actually, improve things? It's a journey, and I do believe it will improve things, but I do think it will take some time. There's already some indications that at least they're agreeing on some data formats, and maybe they're going to be able to kind of reduce duplicity in certain organizations, over time. But anybody's guess. Yeah, exactly.
All right, great. I see that we're out of time. Thank you for the wonderful questions, everyone. And of course, thank you, Dr. Agresta, for your thoughtful discussion on HIE and the landscape. If you have any further questions, please feel free to reach out to Dr. Agresta directly via the email that's listed on the slide. Otherwise, take care. I hope you have a great day.
Thank you.